Hello, everybody. Good afternoon, and welcome to the next event in the TUG Experience series. Today, we have a galaxy of stalwarts from all over the country who are here to debate different issues related to high risk pregnancy. We have two fantastic speakers in the shape of Dr. Charmila and Dr. Preeti Kumar. Both are very well known to audiences all over the country and, of course, internationally as well. We're really privileged to have these two speakers for today's event, which is going to discuss fetal growth retardation as well as new approaches to parental iron therapy. But before we start the scientific proceedings, as always, let me begin by introducing our chairpersons. I'm really privileged to welcome Dr. Parul Kotadawala, sir. Sir is the current Vice Chair of ICOG, Chairperson elect of ICOG, I'm sorry. He's the Vice President of ISOPAG, also the Chairperson for the Education Committee of SAPOG, India Coordinator for NISA as well as AS. He served as the Vice President of TOPSI way back in 2006, President of SOGOG in 2009, and President of the Ahmedabad Society in 2007 and 8. He is also well known to us in TOPSI because we worked with him closely. And my first introduction to Sir was actually when I was working in IIG many years ago, and I observed his skills and his lectures. He's a fantastic teacher. It's really a privilege to learn from him. And he's a very distinguished academician with great volumes of knowledge. Really privileged to have you with us, sir. Thank you very much for gracing the occasion. I'd like to introduce the next chairperson. We are also privileged to have an amazing person, Dr. Shanta Durge. She is from Bidar and she's an activist for the Save the Girl Child movement. She's received several awards, including the Foxy Korean Award way back in 1997, the Distinguished Community Service Award at AICOG 2007, which was held in Kolkata, many poster awards and paper presentation awards at AICOG as well as state conferences. She's received a Bravery Award in Orissa in 2009, and she is faculty at several national and international conferences till date. Since the past 26 years, she has been an activist for the Save the Girl Child movement and to protect girls' rights. And she is one fantastic work in this field. We are really privileged to have her here with us. I would request Dr. Parul sir to speak first, and perhaps he can introduce our first speaker, Dr. Charlie. Sir, please unmute.
The host keeps muting me. Anyway, well, it is indeed a very good afternoon, and in Ahmedabad it is quite a warm weather. I hope it's more comfortable for you all out your place. It is indeed a pleasure to participate in any activities that Pratik designs, and it is always a high quality program. And today also two very important topics are to be discussed, RPL and anemia. Both are, you can say, eternal topics for obstetrics and gynecology. And the first speaker, Dr. Charmila, will deal with the RPL, and Dr. Preeti will deal with the anemia part. It is my privilege to introduce Dr. Charmila. She is Vice President elect of FOXY for 2024, next year. She was Chairperson of Clinical Research Committee of FOXY in 2016 to 19. ICOG Governing Council member. She will finish her tenure this year. National Coordinator for UNICEF FOXY MEDA FOXY PG program and ISAR Gurukul program. Again in current year, series convener for ICOG Journal Club and ICOG certificate courses, WHO Southeast Asia region, MDSR India member. To be honest, she has to highlight what is MDSR. Past Secretary of Trichy Obstetrics and Gynec Society, President, Menstrual Hygiene Management Consortium 2018 to 20, Secretary of Gestrosis India Association, and Secretary of Academic Wing of AART. So as you can see, she has a very distinguished career as an academician, and she will deal with the recent uh, inputs for RPL. Dr. Charmila, please, stage is yours.
Thank you. Thank you so much, sir, for that very, very kind introduction. It's actually on FGR today. And MDSR is Maternal Death Surveillance and Response of WHO, sir. I undertook a certificate course and I'm an India member for that. Thank you so much for that very, very kind introduction. I'd like to thank Pratik for that wonderful opportunity. And Pratik always gives me very difficult topics and he wants me to do it in 20 minutes. So I've tried my best to compile that. So if you want to talk about FGR, we need to remember that it's a pathological inhibition of fetal growth and there is a failure of the baby to attain its growth potential. Placental dysfunction is the leading cause of this condition and it affects approximately 3% of pregnancies. And when you have a baby with FGR, you have to be ready for an increased perinatal morbidity as well as mortality. And the morbidity can be immediate or long-term. The long-term morbidity which has been associated with FGR babies is the impaired cognitive development and the cardiovascular and endocrine diseases which they have as adults. And when you want to classify FGR, the gestational age at diagnosis classifies this disease as early and late FGR. So when you diagnose a disease before 32 weeks of pregnancy, it becomes early. And when it's diagnosed after 32 weeks of gestation, it becomes late FGR. There are two striking differences between these two conditions, and that is in the Doppler studies. Early FGR will have more of umbilical artery Doppler changes, whereas a late FGR will have more changes in the middle cerebral artery in the form of a low PI. And when you want to see the risk factors for both early and late FGR, the minor risk factors as an older mother, mother was conceived by IVF, a nullipara. Suppose low BMI or high BMI, that will be a minor risk factor for FGR. A smoker who smokes 1 to 10 cigarettes per day will have a minor risk factor. A history of low fruit intake pre-pregnancy is supposed to be a minor risk factor. A history of previous preeclampsia is a risk factor for having a FGR baby. And a pregnancy interval which is less than 6 months or more than 60 months, it also adds to the risk factors. Major risk factors are older mother who conceives after the age of 40, who smokes more than 11 cigarettes per day. Suppose there's a history of a paternal SGA or the mother has been born as a SGA baby, that's going to cause problems for the baby. A cocaine user is going to have a major risk factor for FGR. A lady who is following a daily vigorous exercise beyond limits, she may land up with a FGR baby. Suppose there's a history of a previous SGA baby or a previous stillbirth, it's a major risk factor for having a FGR baby now. The history of chronic hypertension is a major risk factor. A lady who lands up with diabetes with vascular disease is having a risk factor for developing FGR in this pregnancy. A history of renal impairment or APLA syndrome is also a major risk factor. And suppose she's got heavy bleeding in the first and second trimesters, it's a major risk factor for landing up with a growth-restricted baby later on. There are some early pointers which you can always think through when you want to have when there's a suspicion that this baby is going to have FGR. The markers would maybe the first trimester or the second trimester. They will predict an early onset of FGR or even preeclampsia. And there are two factors, and that is a decrease in PAPA or the placental growth factor in the first trimester. The most consistent pointer for having a growth-restricted baby. The second trimester markers are an elevation in maternal serum alpha fetoprotein and HCG, which are markers of abnormal placentation. And suppose a lady develops hypertension during a pregnancy, that is an indicator that she may also have a growth-restricted baby. And there is a screening protocol which has been advised based on the risk factors. Suppose the mother has got one major risk factor, irrespective of whatever condition she has, the baby has to undergo intense surveillance from 26 to 28 weeks of pregnancy. And for that, an ultrasound for a fetal size, the fetal biometries should be estimated serially to diagnose a growth-restricted baby. And also the well-being of the baby should be identified with an umbilical artery Doppler. So this is the surveillance which any mother who's got a risk factor will undergo for a fetus sake. Suppose there are 3 or more minor risk factors, you need to do a uterine artery Doppler at 20 to 24 weeks of pregnancy to identify whether the baby is going for growth restriction. The significance of uterine artery Doppler is that we need to know how uterine artery Doppler can be useful and how it may not be useful at all. And abnormality is a PI which is more than the 95th centile with or without a notching. And that Doppler, you do it at 20 to 24 weeks of pregnancy. Suppose she's already a high risk mother with the history of risk factors, then this study will have only a moderate predictive value. It's more of use for a low risk population. Suppose you've seen an uterine Doppler at 20 to 24 weeks and you find it abnormal, and suppose you check it again and it turns to be normal, do not think that the mother is not having a risk of growth restriction. Even a single report of increased PI in the uterine Doppler is associated with an increased risk of FGR. So there's no point in repeating the uterine Doppler once you've done it 20 to 24 weeks of pregnancy. Suppose the report is abnormal at 20 to 24 weeks of pregnancy, this baby will need to be put under surveillance from 26 to 28 weeks of pregnancy. Suppose the uterine Doppler is normal at 20 to 24 weeks, there's no need for any serial measurements for the mother, as in the mother who has got a risk factor. But suppose she lands up with antepartum hemorrhage or has got hypertension, this baby has to put under intensive surveillance. But whatever you do for a low risk or a high risk mother, remember in the third trimester, you will need to follow, because even if it appears normal in the first and second trimester, in the third trimester, after 32 weeks of pregnancy, any baby can go for a late growth restriction. That's why you will need a biometry estimation and an umbilical artery Doppler in the third trimester also. And we have to remember that the diagnosis of an SGA fetus is when the estimated fetal weight is less than the 10th centile. It's so simple as that. Less than 10th centile, you put the baby as an SGA baby. This affects almost 10% of pregnancies, but always remember, FGR is not synonymous with SGA, because 50 to 70% of growth baby which is less than the 10th centile are actually constitutionally small, but the fetal growth is appropriate for the maternal characteristics. They will not have much of Doppler changes. Conversely, remember that not all fetuses with growth restriction are SGA. There may be a normally grown baby up to the 30 or 32 or 34 weeks, and then they would have dropped the growth. That baby is also a growth restricted baby. You will not put it as SGA, because these babies will cross from the 90th to 50th centile prior to delivery, and they are failing to achieve the growth potential. So remember, not all fetuses with FGR will have SGA. It is not mutually inclusive. But remember, when you do an antenatal detection of a small fetus, regardless of whether it's SGA or FGR, surveillance has to be done, because then it will reduce the adverse perinatal outcomes and stillbirth. There is a consensus-based definitions for early and late FGR, which has been adopted by FIGO. Early FGR is when the gestation age is 32 weeks of gestation, at diagnosis, but there should not be any congenital anomaly. And the parameters which will tell you whether the baby is early FGR is the ratio between the abdominal circumference and the estimated fetal weight. If it's less than the third centile, this is an early FGR baby when it's diagnosed before 32 weeks. Even if the centile growth is okay, suppose the umbilical artery Doppler shows an absent end diastolic flow, then this baby also becomes an FGR baby. Or if the baby is between the third to 10th centile, that is, it's a little bigger baby, but when it's combined with a uterine artery Doppler, which is more than the 90th centile, and or an umbilical artery PI, which is more than 95th centile, then this baby also becomes an early FGR. Less than third centile, it's a severe SGA or FGR baby, then it becomes early FGR. And when there's an umbilical artery Doppler change, then also it becomes a growth restricted baby. But when you have a baby which is between third to 10th, with an uterine artery abnormality or an umbilical artery abnormality, this baby also becomes an early FGR. Late FGR, the diagnosis after 32 weeks of pregnancy in absence of congenital anomalies. Here also, the growth centile should be less than the third centile with 2 out of 3 of the following parameters. That is, the ratio is less than the 10th centile. Then it is mutually exclusive. So it will be like, suppose it's less than third centile, it becomes late FGR after 32 weeks of pregnancy. If it's less than 10th centile, or the baby has grown well, but the crossing centile is more than 2 quartiles of the growth center, that is, the growth velocity is not there after 32 weeks, then also it becomes late FGR. But the most important Doppler parameters is CPR or the, so CPR which is less than the 4th centile, or an additional umbilical artery PI which is more than the 90th centile, then it becomes a late FGR. When you want to put the baby under surveillance, there are 2 things you have to remember. There has to be a balance between avoiding a stillbirth and avoiding an iatrogenic preterm delivery. Either way, it's going to cause problems. And if possible, deliver the baby appropriately and correctly so that you can avoid the long-term adverse health outcomes because of the fetal deterioration, the hypoxia, and the acidosis, which can all happen with growth-restricted babies. So suppose you have a baby with early FGR diagnosis, always do a fetal anatomical survey to rule out an anomaly along with a uterine Doppler. A karyotyping is indicated in early FGR. Suppose if the baby has got a very severe form of SGA with structural anomalies, and suppose the FGR is detected before 23 weeks of gestation, it's ideal that you do a karyotyping to rule out any abnormality. And suppose the uterine Doppler is normal and the SGA is very severe, this baby mandates a karyotyping because there's no placental problem, but the problem is happening with the baby's growth per se. And suppose you've got a baby with severe SGA and your karyotyping is normal, do a serological screening for CMV and toxoplasmosis infection because they can cause early growth-restricted babies. And if this is a high-risk population, you need to test for syphilis and malaria. And when you have an early FGR, the important thing is history is very important. The physical examination is very important. Rule out structural malformations in the baby. Look for soft markers. And when you have a suspicion of a congenital problem, amniocentesis and a DNA microarray analysis of karyotyping may be needed. But if the FGR is happening after 24 weeks of gestation, amniocentesis may not be needed because that's usually because of a placental or a maternal cause. But work up for infections when you have early FGR. And the infections which you need to rule out are CMV, toxoplasmosis, rubella, and varicella. And when in the ultrasound, you have got markers which are non-specific and you see echogenicity and calcifications of the brain and the liver, please think about a problem in the baby. And when there's a high drops, you'll need to work it up. And malaria is a known risk factor in our country for a growth-restricted baby. And when you want to compare both the phenotypes, early FGR and a late FGR, usually it's because of placental disease if you can rule out the other problems. But early FGR is quite less common. It's only 1 to 2%. More common is late FGR, which forms almost 3 to 5% of the total occurrence of FGR. Early FGR is quite easy to diagnose because we have our Dopplers now. But FGR, late FGR is very difficult to diagnose and it's very difficult to distinguish from a small for growth restricted constitutionally normal baby. And severe placental disease, which is highly associated with preeclampsia, is the one which causes an early FGR. And early FGR is difficult to manage because the baby is very premature. Whereas late FGR is usually because of a mild placental disease and there's a very low association with preeclampsia. And it's easier to manage because the baby has attained its gestational age. So delivery is an option and you can always save the baby with an optimum gestational age. And when there is a placental dysfunction which is causing FGR, remember there's no effective antenatal treatment for placental dysfunction. And the principal management steps are actually in the institution of the fetal surveillance, and you have to determine the appropriate threshold for delivery for a baby which has become growth restricted. The tools which you have for serial assessment and surveillance is in a low resource setting, the symphysis fundal height estimation is still useful. A fetal kick counting should be advised to the mother. NST, CTG, or biophysical profile can all add to the diagnosis. Amniotic fluid embolism, volume is an add-on to help you in the assessment. But the very most important factor is, most important tool is the umbilical artery Doppler for a FGR baby. And abdominal palpation has got a limited accuracy for the prediction. But when you do a serial measurement from 24 weeks of pregnancy, it improves the prediction of a SGA neonate. But it's always better that you plot it on a customized chart for your own center. And suppose you have a single symphysis fundal height measurement and that is plotted below the 10th centile, or serial measurements demonstrate a slower static growth by crossing centiles, then the baby should be referred for an ultrasound measurement for a biometry. But we have to remember that symphysis fundal height estimation is not useful. The mother is obese and the BMI is more than 35. Suppose she's got large fibroids and there's hydramnions. Then you will need an ultrasound. You cannot rely on a symphysis fundal height estimation. And fetal kick counting, suppose a mother has got risk factors, she has to know how to count the kicks from 26 to 32 weeks of pregnancy. If she is a low risk mother, she can start in the 3rd trimester. The advantage of this test is a very simple test, but the disadvantages are it's got a very low compliance and only gross movements can be appreciated with the mother, and it cannot help to predict a poor outcome for the baby. So the most important parameter which we need for the surveillance is the Doppler study. And for that, the umbilical artery Doppler is the most important tool for that. And it will identify a growth restricted baby which is happening because of a placental insufficiency. The Doppler indices in the umbilical artery will start to increase 160 to 70% of the placental vasculature has stopped functioning. And the main goal will be to prolong pregnancy as much as possible, maximize the fetal maturation by expectant management, while putting the baby under close monitoring until you have got evidence of late Doppler changes in the umbilical artery, which can be a absent or a reversal of the end diastolic flow, or a venous alteration as a ductus venous alterations, or a fetal heart rate abnormality, which points towards a impending stillbirth. So the sequence in increasing resistance is the major pathology is a placental insufficiency. So there will be a decreased nutrients passage to the baby. So what happens is the baby prefers streaming to the heart compared to the liver. So there will be an abdominal circumference decrease. And then the hemodynamic changes happen once a growth restriction is set in the biometry. So the first change will be a reduction in umbilical venous flow. And when that happens, there will be an additional increased resistance in the placental vasculature. And when the resistance in the placental vasculature starts, you will find the changes in the umbilical artery in the form of an increased resistance. So the Doppler changes in the umbilical artery will be because of the increase in resistance in the placental vasculature. And when they tend to increase, and that means 30% of the placenta is damaged, and the pulsatility index is more accurate than the other parameters. And once these changes have started, then it leads on to a decrease in the end diastolic flow in the umbilical artery. And when there's an extreme increase in placental resistance, it will cause an absent end diastolic flow and a reversal of the end diastolic flow. And now you can know, once these changes have happened, 60% of the placenta has undergone a damage. And there will be compensatory changes once these changes happen when the blood flow to the baby is being slowed down. So what happens is the diastolic flow is still seen, but there will be a decreasing middle cerebral artery impedance. So there will be a decrease in CPR, the cerebroplacental ratio. And that tells you that the cardiac output is getting distributed. So that's a very early and sensitive marker of a problem which has started becoming worse in the baby. And this will precede the growth delay by almost 2 weeks. The cardiac function is still normal, so you don't need to deliver the baby at this time if the gestational age is not optimum. Hypoxia may be present, but there's no acidemia, so you can wait on the baby if it's less than 30 weeks of pregnancy. Brain changes usually can be identified in the middle cerebral artery, where the PI falls in the middle cerebral artery, and that means there's a brain sparing effect. The CPR ratio is the umbilical artery vasoconstriction versus the middle cerebral artery vasodilatation. And when it is lower than 1.08, it is pathological. The cerebral Doppler, if it is normal, you can repeat it after 2 weeks. But if it's become abnormal, there needs to be a weekly testing of the MCA along with the umbilical artery Doppler. But it has got a very limited accuracy for an early FGR baby to predict the acidemia and the adverse outcomes, which you'll need to do with a venous flow in the ductus venosus, which will tell you to time the delivery in an early FGR. So the decompensation changes which can happen in the umbilical artery, or an absent end diastolic flow, or a reversal. And then after the umbilical artery flow has having the maximum problems, then you will have abnormal venous flows in the precordial veins like the ductus venosus, IVC, and the umbilical vein. And then additional oligohydramnias, it means as a decompensation in the vein. Venous Doppler changes are the strongest predictor of stillbirth. And it is very ominous if you've got an absent or a reversal of the ductus venosus A wave and the umbilical venous pulsations. And when you have these changes, it mandates an increase of fetal monitoring by admitting the patient. So follow-up in an FGR baby, once you've diagnosed FGR and there is no umbilical artery changes and it's just a growth restricted baby, then you can do the review once in 15 days. And when there's a FGR with a normal umbilical artery flow, you have to do a weekly Doppler. That is, a low-risk SGA is just a constitutionally small fetus, but that also will need an examination once in 15 days. Suppose it's totally FGR, but umbilical artery Dopplers are still normal, a weekly Doppler is needed. When you're seeing a high resistance in the umbilical artery Doppler, then you have to call the patient twice weekly for a Doppler as well as for a non-stress test. And suppose the baby is landed with an absent end diastolic flow or a reversal of the end diastolic flow, daily Doppler is mandatory with the daily NST, and my mother needs to be admitted. And if the baby is less than 30 weeks with an absent end diastolic flow and a reversal end diastolic flow, when you cannot deliver, you have to prolong for at least a week for a steroids and Maxil, probably ductus venosus should be done daily just to prolong the pregnancy. But the biometric measurements are enough if you do it once in 3 weeks. Dopplers need to be much, you have to do it with much more frequency. So we have to think about the utility of the other surveillance tools. You cannot use an NST and an amniotic fluid volume for a one as the only form of surveillance in SGA fetuses. And in the interpretation of the NST is always based on the short-term variability changes and the two from a computerized analysis rather than the analysis we do with the when you look at sheets of papers and try to analyze. And if you see a non-reactive NST, a full biophysical profile is mandatory. And you can interpret an amniotic fluid volume only by a single deepest vertical pocket and not the amniotic fluid index. But if you have a normal BPP and a normal amniotic fluid volume, it's quite reassuring that the baby has not gone for hypoxia or acidosis. So when will you deliver an early FGR baby? Suppose the MCA Doppler is normal and the umbilical Dopplers are still doing quite well, does not progress beyond the high resistance, you can wait till 37 weeks of pregnancy with an intensive surveillance. But suppose the baby has landed up with an absent end diastolic flow and it has already attained a 33 to 34 weeks gestation, then you have to deliver at that point of time. If there's a reversal of end diastolic flow and the baby has grown up to 30 to 32 weeks, you can deliver. And suppose you've got an absent end diastolic flow or a reversal end diastolic flow, baby is less than 30 weeks still, you have to check for a ductus venosus flow. If the ductus venosus flow is abnormal or you're seeing pulsations in the umbilical vein, the viability of the fetus is checked with an NST. Steroids are given. You have to consider delivery even before 30 to 32 weeks of pregnancy in an early FGR. And when you're delivering an FGR baby which is preterm, remember that you need to give antenatal steroids when you're anticipating the delivery will happen before 34 weeks and within the next 1 week. And if the baby has not received a prior course of antenatal steroids, you can always give it the full dose. Magnesium sulfate is needed for fetal and neuroprotection for less than 32 weeks of pregnancy in whom the delivery is likely in the next 24 to 48 hours. The mode of delivery, if you've got a FGR baby which is complicated by an absent or a reversal of the end diastolic flow, cesarean delivery should be considered based on the entire clinical scenario. But if there's only a reduced end diastolic flow, that is, it's not absent or reversed, you can consider a vaginal delivery with intensive intrapartum fetal monitoring. And induction of labor in FGR, balloon catheters are much preferred compared to the pharmacological methods. But if you're well versed in using prostaglandins, it's preferable that use a reversible vaginal dinoprosteron insert, which can be removed whenever the baby goes for a distress pattern. And labor monitoring should be a continuous fetal monitoring, and delivery should take place in an institution which has got an appropriate level of NICU care for the baby, appropriate to the gestational age. And it's recommended that the placentas should be sent for a histopathological examination after delivery, because when you evaluate the placental pathology, that will help to increase the precision of the diagnosis and will provide information on the risks of recurrence in the next pregnancy. And regarding the late FGR, it has been evident that a proportion of third trimester fetuses which are small, reduced fetal size, and they've got normal flows in the umbilical artery, may be growth restricted rather than merely an SGA. We have to remember that the growth restriction happens later in pregnancy. And even though there are normal flows in the umbilical artery, you have to remember that there's a group of babies which can go for an unexpected stillbirth if you don't follow them up. And the concept of late onset FGR is it characterizes the baby with placental failure that is not severe enough to result in an early profound FGR with an abnormal umbilical artery flow, but it is severe enough to be associated with a higher risk of perinatal and long-term complications if you do not deliver at the proper time. And when it sets in after 32 to 34 weeks, can sometimes lead on to unexpected stillbirths. You have to always remember in late FGR. It's more common and it constitutes approximately 70 to 80% of all cases of growth restriction. The challenges in this disease is we cannot identify late FGR as easily as you can do early FGR. And that's why research has been focused on identifying the predictors of poor outcome which is associated with the late FGR babies, because the alterations in the fetal Doppler do not follow the typical pattern of deterioration in late gestation AGR as they do in early onset disease. The Doppler changes are totally different between early and late FGR. And it is associated with a mild placental insufficiency And preeclampsia occurs in almost 10% of cases, and it can happen without even any risk factors like a preeclampsia. And that's why we have to think about whether we should do a routine third trimester scanning for all our so-called low-risk mothers. But when the mother has got major risk factors and she has not landed with growth restriction till 32 weeks, do not stop the serial scanning, because she may develop a late FGR, and that's why serial scanning should be continued till the late third trimester in mothers who have got major risk factors. And is it mandatory that we do a routine third trimester ultrasound to assess fetal growth just to identify a late FGR? There was a big study which was called as a pregnancy outcome prediction study, which analyzed 3,977 women. And they compared in the study between a routine ultrasound versus a clinically indicated ultrasound in the third trimester. And they found out when they did a routine ultrasound to pick up SGA, the detection rate was almost tripled. And that's why it may be necessary that we do a late third trimester scan to pick up for a late growth restriction. And they found out that the risk of neonatal morbidity was increased and the baby's abdominal circumference growth velocity was in the lower decile. And that's why for a late FGR, you have to combine fetal biometry with the fetal growth velocity for a better detection for baby which is at risk of late FGR and a stillbirth. And the Doppler in late FGR, the uterine artery Doppler is of no use in third trimester. The umbilical artery Doppler studies are within normal limits. And that's why this condition is very difficult to diagnose and monitor. And the indirect evidence which you have for a late FGR is the abdominal circumference is grown normally up to the time, drops, and there's a less than 5 millimeters growth in the last 2 weeks, or there's almost a 30% reduction in the abdominal circumference. Then you think about that it's a late FGR, which will not happen with a SGA. Middle cerebral artery Doppler is extremely important for surveillance of late FGR because the oxygen requirements of the fetal brain will increase with advancing gestation. So as a consequence of this, one of the first hemodynamic alterations which occurs in the presence of hypoxia is cerebral vasodilatation. And that's why when you have a reduced PI in the fetal MCA Doppler, it's associated with an increased risk of adverse perinatal outcome and subsequent abnormal neural development. And the CPI ratio, which is more sensitive to hypoxia than the individual components, is a much better predictor of adverse perinatal outcome in a late FGR baby. So when you deliver a late FGR baby, suppose the baby is having growth restriction with with an estimated fetal weight between the 3rd and 10th centile, the umbilical artery Doppler is normal, and the middle cerebral artery does not show any changes, you can deliver at 38 to 39 weeks. But suppose the baby has gone for very severe IUGR and it's less than 3rd centile, or there's a reduced umbilical artery Doppler, then you consider delivering at 37 weeks. Suppose the umbilical artery Doppler is normal, but there's an abnormal middle cerebral artery Doppler in the form of a PI just less than the 5th centile, you will need to consider delivering her at 37 weeks of pregnancy. And so the take-home messages will be for an early FGR, the optimum method to diagnose will be an abdominal circumference and an estimated fetal weight, which is less than the 10th centile. Biometry should be done for a growth restricted baby every 3rd week after diagnosis. Suppose there's a low growth velocity, umbilical artery Doppler should be used as a surveillance tool. If the umbilical artery Doppler flow is normal, you can consider calling the mother once in 2 weeks. Suppose there's a reduced end diastolic flow in the umbilical artery, a weekly umbilical artery Doppler is needed along with an NST. Suppose the end diastolic flow is absent, twice weekly or a daily umbilical artery Doppler flow with NST is mandatory. Suppose there's a reversal of flow in the umbilical artery, you will need to admit the patient, give steroids, do a daily umbilical artery Doppler once or twice, do an MCA Doppler, you have to check for the venous flows in the baby, and NST is also needed before you come to a conclusion of whether to deliver the mother or not. Regarding late FGR, it can set in after 32 to 34 weeks of pregnancy with no risk factors at all. It can lead to unexpected stillbirth because you're unaware that this is going to happen in that pregnancy. That's why a routine 3rd trimester scanning for picking up a late FGR may be considered. The indirect evidence of late FGR is an abdominal circumference growth, which is less than 5 millimeters growth in the 2 weeks prior to the diagnosis, or there's almost a 30% reduction in the abdominal circumference growth. And that's why a combined biometry with the growth velocity should be done serially for diagnosis. And uterine artery Doppler and umbilical artery Dopplers are quite normal in most of the late FGR. And when you have an abnormal MCA Doppler in the form of a PI, which is less than the 5th centile, and a CPR, which is low, it should be used to time delivery. But remember, even in MCA Doppler will not be useful for serial monitoring. That's why you have to have a high degree of suspicion. And these babies can be delivered at 37 weeks of pregnancy. These are my references. Thank you so much, Dr. Pratik, for the opportunity.
Thank you, Dr. Charmila, for taking us through that crash course in fetal growth restriction. I have Dr. Parul Kotradawala back with us. Over to you, sir.
No, if anyone of the audience has any queries, they can put it across in the chat box. It was so complete that I do not have many comments to make.
Thank you, sir.
Thank you very much.
That's one of the biggest compliments, because Parul sir will not accept below par presentations. Thank you so much.
It's above par, not even par.
Thank you, sir. Thank you so much.
I think we had the secretary of the Justice India organization speak about fetal growth restriction, which is the perfect person actually with the updated references and the current concepts in how to manage fetal growth restriction. She did a wonderful job in just half an hour. We covered all the important aspects. Now we have yet another important speaker, Dr. Priti Kumar, who is recognized as one of the thought leaders